Concomitant use of oral glucocorticoids and proton pump inhibitors and risk of osteoporotic fractures among patients with rheumatoid arthritis, a population-based cohort study. Abstract. Background: patients with rheumatoid arthritis, RA, commonly use oral glucocorticoids, GCS, and proton pump inhibitors, PPIs, both associated with osteoporotic fractures. We investigated the association between concomitant use of oral GCS and PPIs and the risk of osteoporotic fractures among patients with RA. Methods: this was a cohort study including patients with RA aged 50+ years from the clinical practice research data link between 1997 and 2017. Exposure to oral GCS and PPIs was stratified by the most recent prescription as current use, less than 6 months, recent use, 7 to 12 months, and past use, more than 1 year, average daily and cumulative dose, and duration of use. The risk of incident osteoporotic fractures, including hip, vertebrae, humerus, forearm, pelvis, and ribs, was estimated by time-dependent Cox proportional hazards models, statistically adjusted for lifestyle parameters, comorbidities, and comedications. Results: among 12,351 patients with RA, mean age of 68 years, 69% women, 1,411 osteoporotic fractures occurred. Concomitant current use of oral GCS and PPIs was associated with a 1.6-fold increased risk of osteoporotic fractures compared with non-use, adjusted HR, 1.60, 95% CI, 1.35 to 1.89. This was statistically different from a 1.2-fold increased osteoporotic fracture risk associated with oral GC or PPI use alone. Most individual fracture sites were significantly associated with concomitant use of oral GCS and PPIs. Among concomitant users, fracture risk did not increase with higher daily dose or duration of PPI use. Conclusions: there was an interaction in the risk of osteoporotic fractures with concomitant use of oral GCS and PPIs. Fracture risk assessment could be considered when a patient with RA is co-prescribed oral GCS and PPIs. Electron microscopy study of 496 cases of lupus nephritis, a single-center experience. Abstract. Introduction: renal involvement is seen in about 40 to 82% of systemic lupus erythematosus, SLE, Asian patients. The exact diagnosis and classification of lupus nephritis are important for treatment and prognosis. This study aimed to investigate the value of electron microscopy, EM, in the diagnosis and classification of lupus nephritis compared with light microscopy. Method: in this cross-sectional referral center 16-year study of lupus nephritis, the final diagnosis was based on the EM study. Primary light microscopy findings were compared with EM diagnosis. Moreover, immunofluorescence patterns distribution was assessed. Results: from 496 patients diagnosed with lupus nephritis based on EM, 225, 45.4%, of patients were categorized in Class 4, followed by 98, 19.7%, 93, 18.8%, 46, 9.3%, and 14, 2.8%, who were categorized into classes of 2, 3, V, and 6 respectively. Only 1, 0.2%, patient belonged to Class I, and 19, 3.8%, cases were diagnosed with mixed 2 classes. Using EM was essential for diagnosing 25.6% of cases taking the correct classification by light microscopy into account. However, disregarding correct classification, this could change to a 7.4% contribution rate of EM. The most common cause of misdiagnosis, disregarding incorrect classification, was inadequate or wrong tissue. Positive associations were detected between tubular atrophy and interstitial fibrosis of both electron and light microscopy with different classes, p less than 0.001. Conclusion: while light microscopy is highly accurate for diagnosing lupus nephritis regardless of correct classification, M contributes substantially to the correct classification of lupus nephritis types. Use of biologics to treat relapsing and/or refractory eosinophilic granulomatosis with polyangiitis, data from a European collaborative study. Abstract. Objective, to describe the efficacy and safety of biologics for the treatment of eosinophilic granulomatosis with polyangiitis, EGPA. Methods. A retrospective European collaborative study was conducted in patients with EGPA who received treatment with biologics for refractory and/or relapsing disease. Results. Among the 147 patients with EGPA included in the study, 63 received rituximab, RTX, 51 received mepolizumab, MEPO, and 33 received omalizumab, OMA. At the time of inclusion, the median Birmingham Vasculitis Activity Score, BVAS, was 8.5, interquartile range IQR 5 to 13, in the RTX group, while the median BVAS in the OMA group was 2, IQR 1 4.5, and the median BVAS in the MEPO group was 2, IQR 1 to 5. In patients receiving RTX, the median BVAS declined both at 6 months, median 1, IQR 0 to 4.5, and at 12 months, median 0, IQR 0 to 2, and the frequency of remission, partial response, treatment failure, and stopping treatment due to adverse events was 49%, 24%, 24%, and 3%, respectively. For the treatment of glucocorticoid, GC, dependent asthma, patients who received MEPO had a much better GC sparing effect and overall response than did patients who received OMA. The frequency of remission, partial response, treatment failure, and stopping treatment due to adverse events was 15%, 33%, 48%, and 4%, respectively, in the OMA group and 78%, 10%, 8%, and 4%, respectively, in the MEPO group. Remission rates at 12 months were 76% and 82% among patients receiving MEPO at a doses of 100 mg and 300 mg, respectively. Conclusion: these results suggest that RTX could be effective in treating relapses of EGPA vasculitis. MEPO is highly effective with a good safety profile in patients with GC-dependent asthma. Our data suggest that 100 mg MEPO monthly could be an acceptable dosage for first-line therapy in selected instances of EGPA, recognizing, however, that this has not been compared to the validated dosage of 300 mg monthly. Association of low muscle density with deteriorations in muscle strength and physical functioning in rheumatoid arthritis. Abstract. Objective: rheumatoid arthritis, RA, is associated with low muscle density due to the accumulation of intramuscular fat. The present study was undertaken to identify predictors of changes in muscle density and to determine whether low muscle density predicted changes in strength and physical function. Methods: patients with RA, ages 18 to 70 years, completed whole-body dual-energy X-ray absorptiometry and peripheral quantitative computed tomography to quantify lean and fat mass indices and muscle density. Dynamometry was used to measure strength at the hand, knee, and lower leg. Disability and physical function were measured with the Health Assessment Questionnaire, HAQ, and the Short Physical Performance Battery, SPPB. Assessments were performed at baseline and at follow-up. Regression analyses assessed associations between patient characteristics, muscle density, and deteriorations in strength and function. Results: muscle density was assessed at baseline in 107 patients with RA. 79 of these patients, 74%, returned for a follow-up assessment at a median follow-up time of 2.71 years, interquartile range 2.35 to 3.57. Factors associated with declines in muscle density included female sex, higher disease activity, smoking, and lower insulin-like growth factor 1, IGF-1, levels. Greater muscle density Z-score at baseline, per 1 SD, was associated with less worsening per year according to HAC, SPPB, and 4-meter walk time scores and a lower risk of a clinically important worsening in HAC score, odds ratio or 1.90 95% confidence interval, 95% CI, 1.06, 3.42, p equals 0.03, and walking speed, or 2.87 95% CI 1.05, 7.89, p equals 0.04. Conclusion: worsening of skeletal muscle density occurred in patients with higher disease activity, in smokers, and in those with lower IGF-1. Low muscle density was associated with worsening of physical function. Interventions addressing reductions in muscle quality might prevent functional decline. Interventions for cutaneous disease in systemic lupus erythematosus. Background: lupus erythematosus is an autoimmune disease with significant morbidity and mortality. Cutaneous disease in systemic lupus erythematosus, SLE, is common. Many interventions are used to treat SLE with varying efficacy, risks, and benefits. Objectives: to assess the effects of interventions for cutaneous disease in SLE. Search methods: we searched the following databases up to June 2019, the Cochrane Skin Specialized Register, Central, Medline, Embase, Wiley Interscience Online Library, and Biblioteca Virtual MSOD, Virtual Health Library. We updated our search in September 2020, but these results have not yet been fully incorporated. Selection criteria: we included randomized controlled trials, RCTs, of interventions for cutaneous disease in SLE compared with placebo, another intervention, no treatment, or different doses of the same intervention. We did not evaluate trials of cutaneous lupus in people without a diagnosis of SLE. Data collection and analysis: we used standard methodological procedures expected by Cochrane. Primary outcomes were complete and partial clinical response. Secondary outcomes included reduction, or change, in number of clinical flares, and severe and minor adverse events. We used grade to assess the quality of evidence. Main results: 61 RCTs, involving 11,232 participants, reported 43 different interventions. Trials predominantly included women from outpatient clinics. The mean age range of participants was 20 to 40 years. 25 studies reported baseline severity, and 22 studies included participants with moderate to severe cutaneous lupus erythematosus, CLE. Duration of CLE was not well reported. Studies were conducted mainly in multi-center settings. Most often treatment duration was 12 months. Risk of bias was highest for the domain of reporting bias, followed by performance/detection bias. We identified too few studies for meta-analysis for most comparisons. We limited this abstract to main comparisons, all administered orally, and outcomes. We did not identify clinical trials of other commonly used treatments, such as topical corticosteroids, that reported complete or partial clinical response or numbers of clinical flares. Complete clinical response: studies comparing oral hydroxychloroquine against placebo did not report complete clinical response. Chloroquine may increase complete clinical response at 12 months follow-up compared with placebo. Absence of skin lesions, risk ratio, RR, 1.57, 95% confidence interval, CI, 0.95 to 2.61, one study, 24 participants, low quality evidence. There may be little to no difference between methotrexate and chloroquine in complete clinical response, skin rash resolution, at 6 months follow-up, RR 1.13, 95% CI 0.84 to 1.50, one study, 25 participants, low quality evidence. Methotrexate may be superior to placebo with regard to complete clinical response, absence of malar/discoid rash, at 6 months follow-up, RR 3.57, 95% CI 1.63 to 7.84, one study, 41 participants, low-quality evidence. At 12 months follow-up, there may be little to no difference between azathioprine and cyclosporin in complete clinical response. Malar rash resolution, RR 0.83, 95% CI 0.46 to 1.52, one study, 89 participants, low quality. Evidence. Partial clinical response. Partial clinical response was reported for only one key comparison. Hydroxychloroquine may increase partial clinical response at 12 months compared to placebo, but the 95% CI indicates that hydroxychloroquine may make no difference or may decrease response. RR 7.00, 95% CI 0.41 to 120.16, 20 pregnant participants, one trial, low quality evidence. Clinical flares. Clinical flares were reported for only two key comparisons. Hydroxychloroquine is probably superior to placebo at 6 months follow-up for reducing clinical flares, RR 0.49, 95% CI 0.28 to 0.89, one study, 47 participants, moderate quality evidence. At 12 months follow-up, there may be no difference between methotrexate and placebo, but the 95% CI indicates there may be more or fewer flares with methotrexate, RR 0.77, 95% CI 0.32 to 1.83, one study, 86 participants, moderate quality evidence. Adverse events. Data for adverse events were limited and were inconsistently reported, but hydroxychloroquine, chloroquine, and methotrexate have well-documented adverse effects including gastrointestinal symptoms, liver problems, and retinopathy for hydroxychloroquine and chloroquine and teratogenicity during pregnancy for methotrexate. Authors' conclusions. Evidence supports the commonly used treatment hydroxychloroquine, and there is also evidence supporting chloroquine and methotrexate for treating cutaneous disease in SLE. Evidence is limited due to the small number of studies reporting key outcomes. Evidence for most key outcomes was low or moderate quality, meaning findings should be interpreted with caution. Head-to-head intervention trials designed to detect differences in efficacy between treatments for specific CLE subtypes are needed. 13 further trials are awaiting classification and have not yet been incorporated in this review. They may alter the review conclusions. Real-life analysis of the causes of death in patients consecutively followed for giant cell arteritis in a French Center of Expertise objectives, to describe, in a real-life setting, the direct causes of death in a cohort of consecutive patients with giant cell arteritis, GCA. Methods. We retrospectively analyzed the deaths that occurred in a cohort of 470 consecutive GCA patients from a center of expertise between January 2000 and December 2019. Among the 120 patients who died, we retrieved data from the medical files of 101 patients. Results. Cardiovascular events were the dominant cause of death, N equals 41, 41%, followed by infections, N equals 22, 22%, geriatric situations, i.e. falls or senile deterioration, N equals 17, 17%, and cancers, N equals 15, 15%. Patients in each of these four groups were compared with the other deceased patients pooled together. Patients who died from cardiovascular events were more frequently male, 46% vs 27%, p equals 0.04, with a past history of coronary artery disease, 29% vs 8%, p equals 0.006. Patients who died from infections mostly had ongoing glucocorticoid treatment, 82% vs 53%, p equals 0.02, with higher cumulative doses, 13,994 mg vs 9,150 mg, p equals 0.03. Patients who died from geriatric causes more frequently had osteoporosis, 56% vs 17%, p equals 0.0009, and had mostly discontinued glucocorticoid treatment, 76% vs 33%, p equals 0.001. The predictive factors of death in multivariate analysis were a history of coronary disease, HR, 2.39, 95% CI, 1.27 to 4.21, p equals 0.008, strokes at GCA diagnosis, HR, 2.54, 95% CI, 1.05 to 5.24, p equals 0.04, any infection during follow-up, HR, 1.93, 95% CI, 1.24 to 2.98, p equals 0.004, and fever at GCA diagnosis, HR, 1.99, 95% CI, 1.16 to 3.28, p equals 0.01. Conclusion: our study provides real-life insight on the cause-specific mortality in GCA patients. The value of ultrasonography combined with clinical features for predicting carotid imaging progression of Takayasu's arteritis, a prospective cohort study objectives, to identify valuable ultrasonography findings combined with clinical markers for predicting carotid progression of Takayasu's arteritis, TAC, on imaging during a one-year follow-up period. Methods: from May 2016 to June 2019, 77 Chinese TAC patients with carotid artery involvement were enrolled in the present study. The patient's clinical characteristics and serological test and carotid ultrasonography results were recorded at baseline and each visit. Carotid progression was evaluated by ultrasonography every 3 months during the one-year follow-up. Baseline clinical characteristics and ultrasonography results for predicting progression on imaging were identified. Results: 16, 20.8%, patients presented with carotid progression on imaging during the one-year follow-up period. The patients in the progressive group were younger, 23.4 plus or minus 3.7 vs. 32.3 plus or minus 9.8 years, less than 0.01, than those in the non-progressive group. At baseline, the vessel wall was thicker in the progressive group than in the non-progressive group, 2.4 plus or minus 0.8 versus 1.9 plus or minus 0.5 mm, p equals 0.041. Furthermore, the proportion of patients with refractory disease, 87.5% versus 16.4%, less than 0.01, was higher in the progressive group than in the non-progressive group. Patients with a thickened carotid wall, equals or less than 1.9 mm, refractory disease and younger age, equals or less than 30 years, might be at a high risk of carotid progression on imaging, 75%, AUC, 0.93, sensitivity, 75%, specificity, 93.4%. Conclusions: younger patients with early vascular structural changes at baseline as well as refractory disease seemed more likely to show carotid progression on imaging. Estimated glomerular filtration rate is a marker of mortality in the European Scleroderma Trials and Research Group, EUSTAR, database abstract objectives. Study aim was to evaluate estimated glomerular filtration rate, eGFR, its association with clinical disease and its predictive ability with mortality in systemic sclerosis, SSC, patients from the European Scleroderma Trials and Research Group, EUSTAR, database. Methods: SSC patients from the EUSTAR database with available items for calculation of eGFR at baseline visit and with a second follow-up visit were included. A cutoff of 60 ml/min was chosen for all SSC patients and 30 ml/min for scleroderma renal crisis, SRC. Cox regression and competing risk analysis were performed to evaluate the role of EGFR as predictive factor of mortality. Results: 3,650 SSC patients were included. Mean serum level of creatinine and EGFR were 0.8 mg/dl, IQR 0.6 to 0.9, and 86.6 plus or minus 23.7 ml/min. The EGFR was significantly lower in patients with pulmonary hypertension. Overall survival, OS, was significantly reduced in SSC patients with EGFR less than 60 ml/min respect to patients with EGFR equals or less than 60 ml/min. OS at 5 years 0.763, CI 95%, 0.700 to 0.814, VS 0.903, CI 95%, 0.883 to 0.919 p less than 0.001. In multivariable analysis, OS was associated with male gender, less than 0.01, systolic pulmonary arterial pressure, SPAP, less than 0.001, and EGFR, p less than 0.001. Cumulative incidence of deaths due to SSC was associated with increased SPAP, p less than 0.001, and reduced EGFR, p less than 0.05. OS at 5 years of 53 SRC patients was not significantly different in SSC patients with EGFR more than 30 ml/min or EGFR less than 30 ml/min. Conclusion: EGFR represents a predictive risk factor of overall survival in SSC. The EGFR is not a risk factor for death in SRC. Severe infections in patients with ANCA-associated vasculitis treated with rituximab. Background and objectives: rituximab, RTX, is an anti-CD20 antibody that selectively depletes B cells and has emerged as a therapy for ANCA-associated vasculitis, AAV, during the past decade. This study sought to quantify and determine potential risk factors for severe infections in AAV patients treated with RTX at rheumatology clinics in Mexico City, Mexico, and Lund, Sweden. Methods: the study consisted of a retrospective case record review, 2005 to 2015, with standardized data collection related to the occurrence of severe infection in 46 patients with AAV in Mexico City, N equals 20, and Lund, N equals 26, treated with RTX during their disease course. Median duration of follow-up from first RTX dose to death or end of study was 26 months. Results: 11, 24%, patients suffered a total of 18 severe infections, infection rate of 11.5/100 patient years. 13 of the 18 infections, 72%, occurred within the first year of treatment. Risk factors for severe infection were older age at RTX initiation and absence of and involvement at diagnosis. In multivariate analyses, age at RTX infusion was the only independent factor predicting severe infection. 4 patients, 9%, died during follow-up, all as a result of infection. Conclusions: severe infections are common following RTX treatment, and mortality due to infection is a major concern. Most severe infections occur within the first year of RTX treatment. The negative correlation of end involvement with severe infection might reflect GPA phenotype heterogeneity. Older age at time of RTX treatment independently predicts severe infections.